Hello everyone, I am Dr. Deepak. I'm Senior Resident from the Department of General Surgery. Topic for today is drainage system in surgeries. So the outline of the topic is introduction. Let's talk about ideal drain, classifications of drain, passive and active drains. We'll talk a little bit about indications of drain, care of surgical drains, and when do we remove them, and few of complications that comes with placing drains. So starting with introduction. Okay, what are drains? Drains are appliances that we use in a surgery or in any procedure that acts as a deliberate channel which is used to drain established or a potential collection, could be blood, pus or air. What is an ideal drain? An ideal drain should be firm, not too rigid, should not be too soft, because it can twist or kink and become blocked. Then it's of no point to us. It should be smooth, it should not irritate the drain site. It should be resistant to decomposition and disintegration. Obvious point. Wide and patent enough to prevent easy blockage. It should not be it should be a non-electrolytic or non-carcinogenic or non-thrombogenic appliance. Okay, when we are using it in a vascular surgery. Classification. So we classify drains into open and closed, which is obvious. I'll show you some pictures. Then active and passive. Okay. Based on function, active and passive matters. Open and closed, I'll tell you. So passive and active drains. So passive drains. So passive drains are the type where we place a drain which simply acts as a by the means of gravity or papillary action. Okay, you don't need to use a suction or an energy to pull out the fluid. Okay, you just place a drain from capillary action or gravitation. The fluid will come out when it's accumulated. Okay, so the examples are corrugated drain, Penrose drains, or sump drain. I'll show you pictures of them in the next slide. So these drains are used when drainage fluid is too viscous. Okay, active drains. So these are tube drains that are aided by active suction. Okay, so example, corrugated rubber drain, Redivac drain, Hemovac, Surgivac, Jackson Pratt. So these two are pictures of passive drain. Okay, so this is corrugated drain, this is Penrose drain. These are pictures of active drains. Okay, so you can see these are all closed drain. We use negative pressure or suction to create a vacuum like effect so that the drain is sucked out into the drain into the cup. Okay, so this is the most common drain that we use. What are the indication? So when do we decide or when do we feel the need to place a drain? Okay, so we have categorized into 5 indication. So first one is therapeutic, second one is diagnostic, third is prophylactic, fourth is monitoring, and fifth is palliative. So therapeutic. So tension pneumothorax. Tension pneumothorax means in the pleural space between lungs and pleura, that is, if there is any air leak, no, that could be because of a rib fracture causing a puncture wound in the lung. So the air from the lung come out, causes a tension between increased pressure outside the lung. No, it causes a tension pneumothorax. So it won't allow the lung to expand because of the increased air in the pleural cavity. So patient will immediately go into desaturation. Patient won't be able to breathe. So for that we place a drain, ICD drain. Okay, intercostal drain we place. So pleural fluid. So instead of air, tension pneumothorax is air. So here it's fluid. It could be hemothorax also. So we place drain tube to allow the fluid to come out. Here we used closed drains, okay, closed drains. Abscess cavity. Now abscess cavity depends on where is the abscess. It could be closed or it could be open, it could be active or passive. If it's externally, it's usually a corrugated drain that we place. Okay, like breast abscess, for example, or it could be an abscess over the gluteal region. We usually use uh, corrugated drains, which is a passive drain. Then seroma formation, acute urinary retention, acute suppurative arthritis, infected cyst. Okay, diagnostic. So diagnostic functions are T-tube cholangiogram for retained gallstones in common bile duct. So when gallstones are found in biliary duct, maybe ERCP or an open procedure, there is a small possibility that a stone might have left behind. So we place a T-tube so that the crushed tubes or the leftover tubes that can come out so doesn't block in future. Okay. Another thing is biliary fistula. Prophylactic. So prophylactic are post surgery when we have done a good dissection or when dissection is significant enough to cause extensive seroma formation or inflammatory fluid that can get collected in the surgical field. What we do is before we close the surgical wound, we place a drain. So if any collection or hematoma or small leak that happens, no, you are giving it a chance to come out so it doesn't get infected, so the wound heals faster. Now if you do not place a drain, the blood or seroma gets collected. It will not allow wound to heal. It will also form a foci for bacteria. Okay. So the examples that I've given are post thyroidectomy, thoracotomy, splenectomy, any major surgeries in abdomen, thorax, in a cavity that involves a cavity, involves an extensive dissection, we place drain. Okay. Monitoring and palliative. For monitoring in gastrointestinal bleeding, we place Ryle's tube. They're talking about Ryle's tube. We place Ryle's tube through the nose, through nasopharynx, through esophagus into stomach. So anytime patient bleeds, it comes out to the tube. Okay. So we can monitor if patient is having any bleed. Urethral catheterization is for Foley's that you might have seen in ward if you have come to ward. They place a Foley's catheter to bring out the urine. Maybe patient is bedridden or patient we have to monitor strict input output monitoring. That those are the times when we use catheterization or maybe patient has retention for palliative reasons. So advanced CAS vagus, hydrocephalus. Okay. So in advanced CAS vagus, uh, it could be something like we place a stent or some Ryle's tube include. We even place Ryle's tube so patient can feed. We put a tube, feeding tube into intestine so patient can feed. So in hydrocephalus, we create a shunt from CSF to another part of the body. So the excess CSF that is produced in the body, or if it's not draining, it goes elsewhere. It is taken out. It is drained out. The care that we need to take when we place surgical drain, we have divided into intraoperative care, securing the surgical drain, and post-op care. So intraop care, it should be placed such that they take the safest, shortest route possible. Okay, should reach deepest, most dependent part of cavity or wound because that's where fluid will accumulate. Tube should remain free of kinks or debris or clot so that the drain works. Should be secured well to avoid falling off or its migration into cavity or erosion of surrounding tissue. Very important. Otherwise, you would cause more harm than benefit. The drain should be lower than the incision at all times. Okay. Securing a surgical drain. A drain have been secured using various techniques, various methods. Okay. So just remember simple. We use a nylon stitch. Okay, we use a nylon stitch to fix the drain to the skin. We take a stitch on the skin, we tie the drain. Sometimes if it's corrugated drain or anything, we come through the drain and fix it. Okay, we also have safety pin, drain clips, adhesives, but what we generally use is a stitch. Post-op care. Post-op care depends on type of the drain, the purpose and the location of the drain. Okay, roughly the area where drain is coming out, that skin should be kept clean. There should not be any fluid or soaked gauze piece around it. It should be kept dry to avoid skin irritation and infection. Skin care should be meticulous. Aseptic technique must be observed while changing the dressing. Gauze should be placed around the drain dry. If it is soaked, we should change it. Okay, to protect the tube, one to absorb the leak from the drain, to assist the stabilization of the tube, to protect from external contamination. Okay, an accurate measurement and record keeping of drainage output. Okay, this is like we will connect to a drain bag. Now this is not possible with corrugated drain. It's possible only with a closed drain. Okay, with open drain you can't record. So drain container should be emptied at least once a day and chart it. So when do we remove drains or when do we discontinue them? So once the drainage has stopped, if there is no discharge, be it air, blood or pus or serous fluid that is coming out, if it has stopped completely or if it has dropped below 25 ml per day. Okay, this is not very specific. It depends on the area where you're placing the drain. So most of the place it's 25 ml per day. Okay, and drain is of no use to us. Maybe it's blocked, maybe it's kinked, maybe it's not working. Then also you can remove it. There's no point in placing them. What is the complication? So the immediate complication is pain, irritation, bleeding, perforation or injury to adjacent structure. Now this should not happen. Fourth one should not happen, but it can happen. Drain can go pierce another organ and form fistula there. What are the early immediate means while placing the drain. Okay, early means after surgery. Okay, so it could get occluded, leak around the drain can get displaced, the drain site can get infected, there could be excessive loss of fluid, electrolytes and protein. Okay, what is late? So pressure, suction, necrosis of bowel or vessel. Okay, one of the rare complication. Fistula can occur, scar formation and hernia. Hernia is less likely, but it is not uncommon. Complication during removal. So patient can have pain, infection, cellulitis or abscess, injury to adjacent structure, maybe a part of a tube has fragmented and left behind. So that is the end of the topic, surgical drains. Okay.